Welcome to Neuro Frontiers, a series in which Practical Neurology partners with ReachMD to discuss topics at the forefront of clinical research and advancements that further clinicians' ability to diagnose and treat neurologic conditions. In this episode, Beth McQuiston, MD, RD, Medical Director, Abbott, and David Okonkwo, MD, PhD, Professor of Neurological Surgery at the University of Pittsburgh, describe some of the important updates in the diagnosis of traumatic brain injuries, including biomarker testing.
Hello, I'm Joe Rusco, Editor-in-Chief of Practical Neurology, and I'm excited to talk to Dr. Beth McQuiston today. Dr. McQuiston, please introduce yourself and tell us about your research related to TBI.
Hi, Joe. My name is Beth, and I am a neuroscientist. I'm a neurologist. I'm also a registered dietitian. I lead global neuroscience research at Abbott Diagnostics, and we've been partnered with the United States Department of Defense since the year 2014.
Excellent. So the ACS recently published best practice guidelines for the management of TBI. What's new in these guidelines?
Oh, so much is new. This is really a groundbreaking time. And a little bit of history before we talk about what's new. These biomarkers actually came out of the United States Department of Defense. They were looking for a quick and an accurate, objective way to evaluate brain injury. And what they found was you can measure brain proteins in the peripheral blood. They then came to Abbott and asked us to optimize it on our handheld platform. So that way they would have a handheld point of care whole blood test that they could measure biomarkers down to the picogram level. And they could do that off of 2 to 3 drops of blood in 15 minutes. So that's the history. Now, talking about where we are today, these blood tests are now FDA cleared, which is absolutely thrilling. We've had over 300 scientists here at Abbott working on this over the past 7 years, and the Department of Defense worked on it for a decade even before that. So now that we have an objective way to measure these biomarkers, guidelines are starting to come out. And one of the guidelines that just came out, or best practices, I should say, came out of the trauma program. So it's the American College of Surgeons, and they put together best practices on blood-based biomarkers. And what they're recommending is that you can measure brain injury biomarkers such as GFAP and UCHO1. That's what we make. And you can use those to rule out the need for brain CT imaging for patients with a suspected TBI who are deemed mild, a GCS of 13 to 15. Huge leap forward. So basically now we have a blood test. We've always had blood tests for the kidneys, the liver, the heart. We've never had them for the brain until now. Huge, huge leap forward.
Thank you. So how can these biomarkers be used to predict functional recovery from TBI in addition to acute stages?
Great question. So they did touch a little bit on that in the guidelines, and they talked about biomarkers and functional recovery. And the studies out there have shown, particularly those by Track TBI, which is one of the largest scale research networks in the entire world. And what those studies have shown is that these biomarkers do correlate with level of injury, which can then predict recovery in certain patients. So those data are out there, and I would direct you to the Track TBI site to take a look at some of those papers on prognostication. It's really a fascinating area. But to do a quick summary, what we should be seeing is low levels of these biomarkers in the peripheral blood. Your brain protein should be in your brain. Your brain protein should not be in your peripheral blood in a significant level. So what you're looking for is low levels of these biomarkers, and that gives you a green light. Now, the higher the markers, that means potentially the more injury could be there. So that's what people are looking at in terms of prognostication. And they do address that in a couple of paragraphs in this guideline and best practices.
Excellent. And so what should neurologists know in addition to what you've already stated about these guidelines when caring for patients with suspected TBI and how to use the biomarkers in conjunction with imaging testing and other assessment protocols?
So right now, what these blood-based biomarkers are cleared for is to rule out the need for a head CT. So you're looking for low levels of these biomarkers. And it's sort of like, if you wanted to do an analogy, it would be like looking at a negative predictive value test or ruling out a PE. We were all familiar with that in blood draws for that. It's similar in this situation. So what you're looking for on the blood test is that the levels are low. And if the levels are low, that means you don't have to wait for the head CT. You don't have to send them in for a head CT. You got the green light. And that can be particularly helpful in a variety of situations. Say, for example, polytrauma, multi-car crashes, busy ER, and you're trying to get people home or get them back where they want to be. And you don't want them sitting there waiting for a head CT. The other big area that's really helpful is CTs, as great as they are, they still expose people to radiation. So not having the patient exposed to radiation when they didn't need to, fantastic. Another big win is for patients, say, that are perhaps inebriated. One of the biggest causes of concussions would be drinking. So it's hard to assess those patients. So being able to say, hey, your brain proteins were low, good, you don't need the head CT, that's very helpful. And then, of course, in elderly, if you don't want to have to transport them from where they are, also it can be very uncomfortable for some folks that are up there in years to wait for a head CT. So it's really lovely to be able to have this option for these brain proteins. Another question that I get a lot is, what else is coming? A lot is coming. So we've seen these consensus guidelines being updated, these guidelines being updated all around the world, including new guidelines have come out in Europe regarding the use of these blood tests in the assessment and evaluation of injury. Also, there have been some consensus groups pulling together new guidelines using these blood tests for Latin America. Same thing in Australia, New Zealand. Globally, there's this groundswell of excitement that we have these regulatory cleared options, a blood test to help evaluate the brain. And now that we have an objective way to help assess injury, guess what's coming next?
Treatment.
Yeah. Now we can stratify people appropriately in the treatment trials. And then we're another step further, prevention. Now that we have an accurate way to measure what's going on in a quick, simple methodology, now we can prevent, because the best problem is no problem. Right, Joe? So that's where we're looking, and it's just exploding.
Excellent. I appreciate that.
So for patients out there and even clinicians, there is a group called Concussion Awareness Now, and you can go to concussionawarenessnow.org or checkyourmelon.com for more information about the signs and symptoms of concussion and various recovery and so forth and so on. So please go there for awareness. And then also one last PSA statement here. Wear your helmets if you're on your bikes, and wear your helmets if you're on those e-scooters. Please be careful out there, folks. Again, the best injury is no injury.
Excellent. Thank you today for your time and your insights. Appreciate it.
Lovely to be here. Thank you, Joe.
We also chatted with a leading neurosurgeon and researcher about other aspects of the new best practice guidelines.
I'm David Okonkwo. I'm a neurosurgeon at the University of Pittsburgh in UPMC. I have a specialty focus in neurotrauma, including patients with traumatic brain injury. On the research side, I have spent more than a quarter century pursuing novel diagnostic techniques for traumatic brain injury, as well as continually pushing the boundaries for how we get better in the treatment of traumatic brain injury.
Thank you. So we're very excited to learn more about the new ACS TBI guidelines. We've previously spoken with Dr. Beth McQuiston, who walked us through the inclusion of biomarker testing in these guidelines and why that's so important. So I'm curious to hear from you about what are some of the other areas that have changed in these guidelines.
The American College of Surgeons best practice guidelines for traumatic brain injury that were updated in the fall of 2024 represent an amazing effort from a large consortium of experts to update and modernize the recommendations for management of critical areas of traumatic brain injury. There are several components to those TQIP guidelines. For me, Two of the most interesting areas that received updates in the most recent guidelines are surrounding prognosis and post-traumatic epilepsy. With respect to prognosis, traumatic brain injury is an enormous public health burden. And for those traumatic brain injuries that produce coma and a life-threatening situation, mortality ranges in the approximately 35% range. But amazingly, the most common reason to die from a traumatic brain injury in the United States is withdrawal of life-sustaining therapy. That is in spite of the fact that we have a large compendium of evidence that shows that great outcomes are possible, and they're, in fact, possible in far greater frequencies than people appreciate. And so in the most recent TQIP guidelines from the American College of Surgeons, there's a heavy emphasis on communicating that evidence to the healthcare practitioners involved in this patient population so that they understand that return to independent living happens more frequently than people appreciate. And as such, the experts involved in summarizing the evidence and producing these best practice guidelines offer a strong perspective that patients should be exuded in the management of this patient population. We have to give patients time. And one of the most fascinating reports to come out in this space demonstrates that on average, it takes 12 days for patients to emerge from coma and regain consciousness, just in the people who go on to return to independent living. And on the flip side, the likelihood of returning to independent living only diminishes by 1% per day following a traumatic brain injury, such that it can take 6 or 7 weeks before you get to a point where you should have a pessimistic perspective on a patient with a traumatic brain injury. I would add one other thing to that. In reviewing data from the National Trauma Data Bank, the most common timeline in America for decisions about withdrawal of life-sustaining therapy is in the first 24 to 72 hours following the injury. And yet, patients with severe traumatic brain injury who return to independent living most commonly take, on average, 12 days to emerge from coma into consciousness. What that means is that these decisions are being made far too quickly in the vast majority of cases.
Must be very challenging to come up with some communication strategies about holding people off from making decisions then.
Correct. The updated TQIP best practice guidelines for traumatic brain injury offer the neurologist who is caring for the patient with traumatic brain injury an important perspective about why it is that patients should be treated aggressively for a much longer period of time than is typically the case in the United States.
That was one of the driving forces behind updating these guidelines, because it's been many years since they were updated. And as you mentioned, lots of different parties were involved in this update.
A major focus for many of us experts who were involved in the TQIP best guidelines development were keenly focused on this issue of prognosis and family communications. We have great capacity to achieve victory, to save lives and restore families following traumatic brain injury. We need to give the patients the best chance to reach those outcomes.
I want to go back to one point that you made about communication. There's communication and strategies in the guidelines for specific populations like older patients as well as pediatric. Those populations were not covered in previous guidelines then.
Correct. With the most recent update to the TQIP best practice guidelines, as a group, we also made it a priority to include the special populations of pediatrics and geriatrics. In the United States of America, we are experiencing a silver tsunami. And in fact, geriatric TBI is experiencing an explosive growth in incidence. The older adult who sustains a traumatic brain injury poses specific and unique challenges for management and recovery. And so we leveraged this update of the guidelines to include data and recommendations specific to those extremes of age, both geriatric and pediatric TBI.
So timely, given the fall epidemic, which is going on right now that we've been reporting on as well.
Yes. In the United States, we have a genuine public epidemic of the older adult who falls and is all too frequently on an oral anticoagulation or antiplatelet medication that increases the risk profile of that fall for creating a more serious event for the brain.
Now, let's pivot somewhat to implementation, which is a broad topic, and there's a dedicated section of the guidelines for implementation.
Here's my perspective. The TQIP best practice guidelines are unique in that it's not purely a summary of the evidence. It also includes consensus from experts about best practices. When it comes to the implementation or adoption of the lessons from these best practice guidelines, it is ultimately up to the individual practitioner to prioritize the education of what the lessons from these best practice guidelines are, to then turn around the next day and implement in their own hospital and in their own practice environment these best practices to maximize outcomes for patients with these difficult injuries.
Makes sense. It's going to take a wee bit of time to absorb all of this, though, in the real world.
Great things always take time.
Now, to switch gears one more time to what's on the horizon in terms of other things in TBI that you'd like to comment on, or are there any other comments you'd like to make not related specifically to the guidelines?
In the decade between the versions of the TQIP best practice guidelines, countless things changed in the world of traumatic brain injury, virtually all of which were for the better. We now have biomarkers as blood tests that we didn't have before. We have seen a significant increase in the focus on individualized, personalized care, such that we are trying to create the best interventions for the patient in front of us. It is a golden age of research and clinical care for traumatic brain injury. We have gotten so much better in the last decade, and we are genuinely primed for some very significant breakthroughs in this field when it comes to diagnostics and treatments. We have seen a robust evolution in the recognition of the value of post-acute care and rehabilitation. We are seeing the maturation of care pathways that extend beyond the hospital all across the country. We still have a tremendous amount of work to do. We have tremendous gaps in our care system for traumatic brain injury in the United States, but there is a genuine collective will and dedication to getting better each and every day.
That's great news. Thanks for sharing that. It's no longer death sentence, and the importance of personalized care. And as you mentioned, a shout out to the PT and OT and rehab folks in the world is welcome. So thank you for that.
I would echo the blood-based biomarkers for traumatic brain injury represent a very important leap forward in the tools we have in our armamentarium to understand best the patients who come under our care. Bringing these TBI blood biomarkers to fruition across the finish line at the FDA is a remarkable testament to the strength of partnership, wherein an academic consortium, an industry partner who's dedicated to this, and the Department of Defense recognizing the value of this both to military and public health is a giant victory for the field.
Thank you. And you see that expanding outward in the examination of biomarkers in other acute areas, like in stroke, in the EMT vehicle, looking for biomarkers.
In the same way that traumatic brain injury was a part of the earliest moments of clinical guidelines. Traumatic brain injury is also in the earliest moments for biomarkers for neurological disorders. And the successes that we have seen in traumatic brain injury will get copied and pasted into several additional neurological disorders in the years ahead. We have genuinely reached a game-changing moment for not just traumatic brain injury, but neurological disorders in general.
Yeah, I can definitely see it in stroke coming. So that's wonderful. It's a model for these other or subspecialty areas.
Yes.
Thank you so much for your time and your insights.
Thanks to Doctors McQuiston and Okonkwo for sharing their knowledge with our listeners in this episode of NeuroFrontiers. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the field of neurology.